Good afternoon, everybody. Apologies for being a little late. Traffic surprisingly was worse than expected. So give me 1 minute, and I'll pull up the slides. Merry Christmas, Happy Holidays, everybody. There we go. Perfect. Just make sure I can see. Let me say hi to everybody in attendance. Debashish, always great to have you. Ethan, Marguerite, I see I have you in twice. Peter, Pratik, Tom. It's a small but merry crew today. So glad to have you all here. Let's get started. Hopefully we can end a little early and spend some time with our families. So Japan still seeing an increase in our 7-day average cases, which, you know, from the reports that we've been getting from our state partners, there hasn't been too much of an appetite for huge increases in Japanese tourism and visitors here, either because they're experiencing a surge or because they have to quarantine for 14 days on the return. So still worth watching. And I know South Korea is increasing, and Thailand also has a massive increase this past week in the South Pacific. Nationally, hopefully, it looks like we're turning the tide in this holiday surge in terms of cases. But what's not pictured, but to be expected, is an increase in hospitalizations, ICUs, and fatalities. Once again, we know that there's a lag a couple weeks after the cases increased. Arizona and California, as you can see, hopefully once again mirroring our national curve, is on a downward trend. Hopefully, but we will continue to monitor those states. We'll see what the impact Christmas has and New Year's will have on these major states that impact Hawaii in terms of tourism and our residents traveling there. Nevada, hopefully continue to downward trend as well. Texas, unfortunately, doesn't look like it's really turning the tide yet. We'll continue to monitor Texas as well. Moving on to our Hawaii overview, cases per 100,000. Oahu County definitely increased a few days ago. However, a bunch of those cases were due to that Halaapa Correctional Facility cluster, but was still included in our calculations. However, Mayor Caldwell did clarify earlier this week in one of his press conferences that he got the okay, and please, Victoria, correct me, or anybody else, correct me if I got this incorrect, but he gave the green light to exclude correctional facility case counts from tier calculations. So it'll still be you know, the actual numbers will still be included in our daily case counts, but for the calculation of whether or not to regress back to a more strict tier, they will not factor that in. Even so, if you look at the percent positivities across counties and for the state, Oahu definitely above that 3% threshold for tier 2, which would technically put us back at tier 1. And because of Oahu's increase, bringing up the overall state positivity rate. Kauai continued to trend down, which is great. I know there was a scare the past few weeks with a huge increase in Kauai's percent positivity and case count. And it's always good to see a downward trend and holding steady in Maui and Hawaii County. Maui County had 33 cases today, so about 1/3 of the cases today. Testing turnaround time continues to be great, and you can also look at our testing volume. It is relatively constant, which shows that we are doing a good job. We're not really falling behind. And then in another report that's not pictured here, we're not doing too much in our surge testing, and when we do search testing, we're not really catching a lot of positive cases. So really positive for our testing turnaround time. Moving on to our forecast, Levi is now on the mainland for a few weeks. So he's on a different time zone. I think he's 5 hours ahead. So I'll be taking over his slides. Once again, you can see our pessimistic and then our reasonable expectations in terms of our increases. We haven't seen really much of an evidence of holding steady, which is why our blue line still shows an increase. However, there's nothing right now to suggest a massive surge. So there's not that big of a disparity between our blue and our red lines. Fatalities will continue to be constant. Once again, remembering that that's the hardest metric to kind of forecast out. Hospitalizations, ICUs, still once again a proportion of our cases, but nothing that we've seen in terms of capacity to indicate that our statewide and county, at least on Oahu County, we're near any type of overflow right now, thankfully, which is not the case on the continental United States. They've been paying attention to the news this past week. And here's just a breakdown of what you just saw on the previous slide, but more numerical breakdown. Not gonna spend too much time on this. Once again, knocking on wood, we've gotten through. Let me go back one slide just for everybody here. We've gotten through surprisingly Halloween and Thanksgiving without a crazy increase, which is what I was expecting. Hopefully, if we can get through Christmas and New Year's, I'll be optimistic for the new year. But you know, continue messaging about vaccines and what they can do. And you know, with the holidays and COVID fatigue and people seeing great news, I think there's an opportunity for people to let their guard down again. So once again, with all your friends, continue to message, which I know you guys are doing great education efforts. So 3 science highlights. One of that second one, little certain about UK COVID variant. Marguerite's definitely going to talk about more. But throughout the week, there's been more and more information and data that's been released on that. So I just wanted to put the link up there for you guys to click on, but I'm not going to really speak too much about that. I will speak to the first one, a person who went out to work while sick in Oregon, responsible for 2 separate COVID-19 outbreaks. And then CIDRAP, 2 studies found that COVID-19 antibodies last 8 months, and they use 2 different methodologies, which I still won't go too much in depth because that's not a biologist or virologist. So once again, the takeaway from this story is continue the simple things. Definitely stay home when you're sick. I know it's harder when you're asymptomatic, but definitely when you're just feeling under the weather, stay home, wear a mask, wash your hands, physical distance. This one definitely could have been prevented, but this worker went to work anyway and got coworkers sick. And like we've talked about multiple times, there's a tendency to just lump super spreaders together, but there is a clear delineation between super spreaders and super spreader events, and understanding how that impacts modeling, but also just communication and action as well on the policy side. And then, so really on a higher level on these 2 studies, major conclusions, we are getting more and more evidence that if infected with COVID, you can have some or more long-lasting immunity. I know earlier in the year, we weren't sure how long, if at all, immunity would last. We would see people test positive 2 months after infection, but that was, we're learning that's probably due to very sensitive PCR tests and just very long viral shedding durations. That first study from Australia showed memory B cells, not the IgGs, but the memory B cells rising up to 150 days post-infection and remaining detectable 204 days post-infection. So it's about 8 months. And then the other study that was published in the CDC Emerging Infectious Diseases showed 0 positive results 2 to 3 months post-infection. which contradicts previous findings. So once again, still waiting for more and more data, but this is positive news, especially with the COVID, with so much attention being paid to the vaccines. And, we're still waiting on data in terms of how long the vaccine efficacy lasts. But once again, we're getting more and more data to suggest positive results. Some takeaway education messaging is that even with this information and with vaccines being rolled out, mask wearing, the simple things that we've been preaching the entire time, will still need to be taken through the end of probably 2021 and into 2022. I know the WHO had a report last week saying that a bunch of lower socioeconomic status countries in the world probably won't get wide access to vaccines until early 2022. So with global travel picking up and business picking up, we still need to be cautious and take as much mitigation steps as possible. Let me see if there's any questions, which I haven't seen. Let me see. Nope. With that, I'm going to stop sharing. And Marguerite, the floor is all yours.
Oh, thank you. Okay, can you see my screen? Can you hear me?
Yes, we can hear you. We're just waiting for your screen to pop up.
Okay, shoots. Sorry. I'm on my iPad. I'm giving that a try, so hopefully it will work. Okay, well, if this doesn't work, then I will switch to my laptop. Okay, shoots. I think my internet is too slow for this iPad, so let me switch over to my computer. Okay, can you switch me to the other entry? Sorry.
No problem. Rukia, can you help Marguerite with that, please?
Okay, I'm so sorry. Okay, I'm so sorry. Okay. Okay, let me share screen. Okay, sorry about that. Okay, now can you see my screen?
Yes, we can.
Okay. All right. Okay. I thank you very much. Merry Christmas, Happy Holidays to everyone. But sorry to drag you in here, but there are some important things going on in the world of SARS-CoV-2, and I'm trying my best to share with you what I learned. This is really emerging, very recent information. This is a report by the CDC of Europe. And so they just reported that the cases of COVID-19 are rising rapidly in the south of the UK over the last several weeks. And because they have a very huge genomic surveillance effort underway, they were able to actually identify that the majority of those sequences belong to a novel variant. So this new variant has 17 mutations. And what's surprising about that is that they basically arose all at once, which is really unusual. Typically mutations arise one by one by one. So the fact that they arose in concert is a strongly suggestive that this is natural selection on the virus. Okay, so 9 of those mutations are in the spike region. And the functional effect is that it increases transmission by about 70% is the estimate. And the concern is that we could increase infection, so viral reproductive number by 0.4. And so like other mutants that have arisen, there's no indication of increased disease severity or mortality. It just seems to increase transmission, which is pretty typical for viruses. Typically, over evolutionary time, they tend to get more transmissible but less virulent. And these are the 9 mutations that are in the spike, and I'll talk about them a little bit later. Okay. So the cases rose sharply, as you can see from this graph. And one thing that's been noted in the press is that the greatest rise, it's a little bit rising faster in teens and young adults as opposed to older adults.
Marguerite, sorry, we're not seeing the slide advance.
Oh, geez. You haven't seen any of the slides advance?
No, well, I'm still seeing the title slide.
Oh man. Okay.
If it helps, I also see a small colors box, so maybe it's just which screen you're sharing.
Okay. Let me try sharing the desktop. Oh my gosh, I'm so sorry. Okay, let me. Let's see, okay. Slide.
No, oh wait, no, here we go. There, okay. Yep, see the slides now.
Okay. Okay, can you still tell me if you can't see the slides?
Yep, we can see it so far.
Okay. Okay, so yeah. Okay, so this is what I had just covered.
Oh, now all I'm seeing is just the rapid increase of SARS-CoV-2 variant slide, but nothing else.
Okay. There's no figure there?
No.
Let me try sharing. Maybe don't do present mode. Okay. Let me try that. Okay.
Yeah, we can just do this. This works.
Okay. I'm so sorry, everybody.
No.
Not sure if it's a connection issue or what. Okay, the cases rose sharply. Yeah, and so you can see by the colors that it does seem to affect the younger people, or it's transmitting across the younger people more. And the concern is that the new variant, well, anyway, the new variant is replacing other genotypes. And we've seen this in other genotypes that have swept through, like the D614G mutant. Okay, so the questions that came out in the report, and that are the big questions, I believe, are that, will there be wider spread or greater disease severity? will the vaccine still work on this new variant? Can the new variant escape detection, either by PCR or antigen tests or whichever diagnostic tests? And then is there going to be increased potential for people to get reinfected? Okay, so just, I'm not sure if I need to actually review this for people on the call, but this is also a little review of how coronavirus enters our cells. And so they enter via, so this is the virus, as you know, and each of these is a spike protein, and it enters via interaction with the ACE receptor. And so, so for the public, I guess it's important to reiterate that the vaccine is only presenting the mRNA that produces only the spike. So it would never cause an infection because you don't get all of this viral replication and production and cell killing that happens in an actual infection with the real virus. But the important thing for this is that the spike protein is a complex molecule with like over 1,200 amino acids. So it's this 3D shape. And when you're injected with the vaccine and your body is exposed to this protein, you generate hundreds, if not thousands, of antibodies if you're a healthy individual. So the antibody response generates a large population of antibodies. And so the antibodies work by sticking all over the virus to the spike protein and covering it up so that it can't enter our cells. So here's one article that was really good news, and it touched upon what Thomas was talking about, that there's robust neutralizing antibodies for natural infections. So this study found that what's important here is that they studied mild to moderate symptomatic people, not the severe cases. And they found that even those with milder symptoms had really robust immune responses. Most individuals, the vast majority of individuals, had strong neutralizing antibody titers, and moreover, it persisted for over 5 months. So that's hopeful. Yeah, but how concerned should we be about new variants? And so, as we know, mutations occur all the time. And there's already been documented thousands of mutations, or more than 1,000 mutations thus far. This is the spike protein, and there are a lot of mutations there. This is a slide that Claire showed in a previous talk about the D614G. And there's also hot zones that tend to have a lot of mutations in the spike. And one piece of good news is that D614G mutation is actually pretty responsive to antibody treatment. And so even though it causes more infection, it doesn't seem to affect the therapeutics. And anyway, okay, so this is one point, is that it's associated with infectivity, but not mortality. So that's a really big thing to keep in mind. But there are some pretty serious issues for concern. And so the first really strange question is, how did we get a new variant with 17 mutations basically all at once? And so there's a science news and views about this that you can read, and it's pretty interesting. And one really tantalizing study that came out followed an individual patient. And this was an immunocompromised patient who had cancer and was infected with SARS-CoV-2. And so the concern is that given that both the vaccines and therapeutics are designed against the spike, there's a theoretical possibility of viral escape from those defenses. So as we've said many times, the virus mutates at an average rate about 1 to 2 mutations per month. But so typically that means that as it passes from one host to another, it accumulates one mutation on average. Okay, so how do we get the situation where we get 17 at once? So an immunocompromised individual doesn't mount an antibody response. They're not really able to fight the virus. Okay, so the immunocompromised individual offers the opportunity to the virus to stay in the same host for multiple replication cycles. And so they actually were studying this patient. He was a cancer patient. Oh, I'm not sure actually if it's a man or a woman, but it was a cancer patient that was infected for 101 days and finally died. And over this period of time, they were sampled 23 times. So they actually have the genomic sequences from these samples. This person was treated with remdesivir. And over the first 65 days, there was no change in the strain. And so that person had 2 doses. And then after that, without improvement, they tried convalescent plasma. And then at that point, the variant strain emerged with several mutations now present, but the virus eventually waned. And then finally, they did one more dose of convalescent plasma, and it was unsuccessful. But what happened was the variant strain arose. So it looks, so I guess they tested it in vitro, and they found that this spike escape variant is what they're calling it. They identified the amino acids that changed, and they are kind of on the outside of the molecule, which is what you might expect. And it has decreased sensitivity to the plasma, the convalescent plasma. But it's highly infective. So what they're suggesting, the results from the study, is that the convalescent plasma treatment on immunocompromised individuals creates a positive selective environment for the virus. So we're actually, basically selecting for more efficient strains of SARS-CoV-2. So that's the fear. Okay, so going back to the mutations, there were 17 mutations, and 9 of them are on the spike protein. This D614G, which was the one we were watching before, is there. It's present, but in addition, there's a number of additional mutations. There's a couple of deletions and then a number of substitutions. Okay, so the concerns for public health are that the deletions and mutations might interfere with the diagnostic tests. So if you're missing a piece of that sequence, your PCR primers might not work, or other diagnostic epitopes might not be there for the test to work. So, but that can be monitored. And so the labs that are doing the testing should remain vigilant. And typically the tests involve testing for multiple proteins. So that's something that people can just be aware of and try to remain vigilant about. The bigger concern, perhaps bigger concern, is that of further immune escape. If the mutations are blind to the immune system, then the virus can evade the defenses that we're mounting. Okay, so what the recommendation is genomic surveillance to monitor the genotypes as they move through populations. What's happening, and are new genotypes arising that we should be concerned about? And then I think more carefully targeted tracking of patients, especially for either at risk of reinfection. So if your immune defenses, if the virus is mutated and can escape the immune defenses, then there's a possibility that you could get infected with a new strain. Or a vaccine failure is what people are worried about. Okay, the positives, however, is that the spike protein is a large conserved protein. There's over 1,200 amino acid residues. And so there are lots of targets for antibodies to stick to. And it's an amazing thing that our immune systems generate many, many, many antibodies that stick all over the molecule. So the reason why people scientists are not freaking out yet is that even if we have a number of mutations, we should still have enough types of antibodies that are generated by our immune response that we can still neutralize the SARS-CoV-2, and so that it should still work. It should still work for some time until like enough mutations occur that then the immune response generated by the vaccine is no longer effective. But at that point, another mRNA vaccine could be developed, because it's pretty easy actually to just design a new mRNA. And so all that would require is just, you know, a little more testing and regulatory approval, although that should be a lot faster because of all the prior testing that went into place for the first one. So I guess my take on it is that it's kind of something to be watching very carefully, but hopefully, but it's not something that's going to defeat us. Yeah, there are enough defenses lined up, and our defenses are pretty awesome. So I guess at the end of the day, what we really need to do is our standard public health measures and reduce the opportunity for mutation, right? So this arose because of the millions and millions of cases that are out there. So if we are able to wear a mask, social distance, prevent infections, and get vaccinated as soon as possible, that will really help us win this war and not help the virus. So that's pretty much all I had. Hopefully that was somewhat informative. Sorry about all the technical issues.
No, thanks so much, Marguerite. I learned a lot, and I'm sure everybody else did. This is definitely outside of my wheelhouse, and I think you definitely clarified and reaffirms a lot of the points that I was trying to draw, but I wasn't quite sure because a lot of this is very technical. So I think the takeaway and the take-home messages will be important to share with all of our partners in terms of where, vaccine, this is not a negative thing in terms of, okay, vaccine, let's not even get the vaccine, vaccines will still work based on what we understand, but this is nature doing its thing in terms of, trying to keep this virus alive, and just messaging that as simply as possible and connecting that to the public health measures. So I took a lot away from this. So.
Oh, the other thing is that there's also a South Africa mutant, and yep. It shares some of the mutations, and so it does look like it's independently evolved. So it is definitely a race, and so I just think the faster that we can get as many people vaccinated as possible, the better off we'll be.
Yeah. Do you, and I know we asked Ethan about this previously, but are there, it's a lot harder to do this at least within the United States. Do you know of any, like the CDC or NIH, are they spending a lot of time or efforts trying to track it within our country?
I know that they're promoting, but I don't know. I know that there's a consortium of genomic sequencing, but I don't know how much resources are put into place. And I mean, really, it has to come from all the departments of health and the public health agencies that can sequence. I just know that the UK and Australia are trying to sequence every single patient. Wow. But even to have some would be wonderful.
Yeah, and I know we talked previously in terms of, or on one of our previous webinars, that we could use the same swab for the PCR and use that same sample to
maybe
run
Janet is on.
I think
if she could
on.
Speak to that. Oh, I know that. So I did have some correspondence with Ed Desmond back in September, and he said that he was going to be sequencing all of the Hawaii samples, but I don't know anything beyond that, and I haven't seen the sequences actually published or, you know, shared anywhere. But yeah, if somebody else knows, I would love to know.
So this is Janet Berryman. I know that we have the capacity to do genomic sequencing. There's no possibility that every sample in the state would be sequenced, and I'm sure that that's not what Dr. Ed Desmond said. He may have said that they were going to sequence the samples that come through the state laboratory, which is a small minority of the samples that are run statewide. As you know, they're mostly run in commercial labs. With the surge testing, they're going to mainland labs. But I don't know what level of sequencing they're doing, how they're selecting samples or anything. I don't know if Josh Quint is on the phone, but he or I could certainly send that inquiry to Dr. Desmond and try to bring back information. It's not the sort of information that would go on the public website because it's not meaningful to most data consumers.
Thanks so much, Janet. No, that's helpful. But I think just bringing more awareness to the possibilities of this, and you know, the fact that this has garnered a lot of international and national coverage in the past week speaks to the need and the focus on this, and continual surveillance is not just because it's in UK right now, but moving forward for a long-term approach, not for just, you know, SARS-CoV-2, but potentially for other future, God forbid, pandemics, you know, or at least surveillance to make sure it doesn't get to this point. So this is definitely a great slide deck and a great presentation, Marguerite.
Yeah, I think the big concern is that this is the first strain that has people worried about the possibility of viral escape. That's, I think, the big thing. And so it's just sort of, we have to redouble our efforts to try to knock this thing down.
Yeah, I think the overarching consent, like the message is that, okay, vaccines are here. Once everybody gets vaccinated, COVID is squashed. We don't have to ever worry about it, which hopefully is the case, but with what we're seeing, that may not be the case. So just continue vigilance and messaging. I know the primary focus right now is on the vaccine efforts, and rightfully so, but it's good to have everybody, all the experts, continue to monitor future potential threats and concerns, so that we can kind of bring it to the decision makers ahead of time and not try to react so much. One thing that, and I wish we had a bigger group, but we can definitely talk about this next week, or the following week after the new year. And I know this is going to be, especially with Hawaii, a big topic point is, I was reading, I think EVA Air is looking to require all passengers in the future to get vaccinated in order to travel on their airlines for COVID. So I only suspect that's just the tip of future discussions and debates on whether or not, you know, we bring back the yellow card from, you know, for the vaccine, or, you know, how we're going to implement that at a national, international level, how it's going to be consistent between states, all that very fun and contentious, potentially, discussion in terms of how do we, you know, track, and do we require people to get vaccinated to travel. So just thought I'll bring this up because it does tie into the global nature, you know, and the fact that I'm sure at this point this potential strain has made its way to the continental United States. I know it's made its way to other European countries as well. So for whoever's on the line, I just, you know, if you have comments, raise your hand. Just love to hear your thoughts on, you know, how our you know, what do you think is the best way? If you've heard of any talks about, you know, requiring vaccines to even travel? I know Lieutenant Governor was talking about using the vaccines in lieu of a test, but you know, there's a potential for people to take this step further and require a vaccine to even travel. So just probably, and with that question, and there's, it's a hugely complex question, but one that I foresee taking the headlines in a little bit as we get more and more people vaccinated.
Oh, Tom got vaccinated yesterday. Woohoo! That's awesome. Actually, I was wondering if we can ask Janet or anybody who knows, like, how are people finding out that they can get vaccinated? Like, how is the whole notification and management happening?
Well, right now, there are these ACIP and CDC and state priority groups. So the first priority, and in the first tier, there are 3 sub-tiers, 1A, 1B, and 1C. 1A is healthcare workers. So people are being notified essentially through their workplace where they, what the procedures are and where they can get vaccinated. So it's not a public notification, it's an individual notification by your place of work or employment. Also by, the health department is doing, to the extent that we're doing outreach, it's focused on independent healthcare workers because the hospitals are responsible for everybody affiliated with them, and the hospitals statewide are also largely being willing to bring in independent healthcare providers as well. And then the health department is doing some outreach to some of those smaller independent providers to make sure that we don't miss anything there. The other component of Group 1A is residents in long-term care facilities. And there's a federal contract for CVS and Walgreens to provide those vaccinations to all residents of large long-term care facilities nationwide. So again, if you're a resident in a long-term care facility, the vaccine will come to you. You don't have to do anything active about it, although you do have to consent, or whoever, if you're not able to, whoever is responsible for making your decisions is responsible for consenting. The 1B category includes sort of frontline high priority essential workers. It was changed over the weekend. It used to just say essential workers, but that was a very large percentage of the workforce. So that's primarily looking at first responders, EMS, that sort of people. And again, they're being notified through whatever employer or entity they work for of where the options are. So these are all what we would call closed points of dispensing. They're not open to the public. The next group that we're looking at is, 2 other groups. The long-term care facilities, the federal contract is only for large facilities. So there are small home-based adult residential care homes and foster homes and things for people with developmental disabilities. So the health department is reaching out to those through the various organizations that represent them in order to coordinate with them and get vaccinations there. The next group that will be kind of the first dipping our toe into the more general public is that people 75 and older are in that 1B group also. And how to outreach to that group is actually a little bit challenging because a lot of the outreach depends on has depended on email and basically electronic communication that we know that in that age demographic is going to reach a smaller and smaller proportion of people, especially as you get further up into that age demographic. So we're working with the offices on elderly affairs and with healthcare providers and still fleshing out what the opportunities and mechanism for reaching those people will be. And after that, it's all other essential workers and people 65 and older and people with chronic health conditions, which begins to be most of the population. That's when we'll be in much more open points of dispensing, and we'll also be relying on healthcare providers, clinics and offices to become enrolled providers and have vaccine and be able to get it to their eligible patients. So that's a very long answer to a short question, but it doesn't actually have a simple, straightforward answer.
Yeah, thank you. It's a very complicated situation.
Thanks so much, Janet. I will add, and then I think we can end a little early, that it from my work, my past few weeks working in the Army, and we're trying to figure out how we move from our individual phases. It's everything looks very neat on paper, but when you actually try to operationalize it and try to figure out when to go from one sub tier to the next sub tier, who to give the okay, how to manage it, how to track all of it, it becomes a headache. And I can't speak for what the state's doing, but I can only imagine that it's a huge logistical lift, even with all the planning. So, and this is with a very smaller batches and smaller ends of people who are going to get vaccinated in the first couple tiers. So hopefully we'll get the kinks out of the way, and when we get to the mass vaccinations, which I think will actually be easier. So
you know, at that point you'll be having to convince people to get vaccinated.
We've been trying to convince. Surprisingly, some providers don't want to get vaccinated right now either. So
oh my God.
It's surprising, not surprising.
I don't know if anyone has any questions.
I was going to add one more thing about those tiers, which is that I think it's important for people to know that the intent is not to get to completely saturate one priority level and then move to the next. It's to start with one and then bring in the next and bring in the next, recognizing that you're going to be working across multiple tiers at the same time.
Yep, absolutely correct. Thanks, Janet.
Yeah.
Yeah, and I think that's when we see that type of kind of hierarchy flow chart, how, you know, what you make, people think that it's a zero sum where like you have to hit everything before you move to the next one, and it's just a way to prioritize, but it's not necessarily, like you said, going to be 100% in one tier before you get to the next. I don't see any questions in our Q&A. Everybody on attending today has brains on days, so I think you guys all synthesized this much better than I did. I want to thank you all for participating on Christmas Eve. Thank you for your dedication and support, and please enjoy this long weekend, this time off, hopefully if you have it, and we will see you next week Thursday, and happy holidays and enjoy time with your family. Thank you, everybody.
Okay, thank you. Bye.
Thanks, everybody. Bye.